So I wanted to welcome you all here tonight and to thank Dr. Robert Gluckman, who I'm going to talk a little bit about as we go through the evening, because he and I really got started on this several months ago, and I'll tell you a little bit about that story. Why are we doing an NCDR meeting here in Portland? Well, it all started last October when we had what at that point was called the Medical Directors Institute, or a mini Medical Directors Institute, which was a pilot program that grew out of a large Medical Directors Institute that had been taking place for several years in Washington, D.C. with the national ACC. It was felt that it was losing its punch. It really wasn't being productive. Since most healthcare was local, there was a lot of feeling that we could do better by trying to engage with what was going on locally. And Oregon was one of 3 states that initially was able to participate in this. And at the Medical Directors Institute, I presented some of the Oregon data. And we were actually pretty proud of that, and I'm going to show that to you as well. But while I was doing this, Dr. Gluckman was busy on his fancy computer playing with his data, which he showed me, which was a little more disturbing than the data that I was so proud of. And so we started talking and working together a little bit about what we can do together to improve quality for our patients. So I wanted to try to explain to you a little bit about why the NCDR registry, which is really our registry, is really a mystery to cardiologists. Well, it turns out that the NCDR contracts with hospitals. The hospitals are actually the NCDR participants. The data input and analysis of individual data is performed by the hospital. And until recently, when we started seeing some of this data, cardiologists really neither saw this data or had any input into its quality. Since recently we're getting push from the payers, the government, the Department of Justice is looking at ICD implants, and of course Dr. Oz, and I'll tell you a little bit more about him. But nationally, there's been a lot of publicity about the results of the database at a time when we are still a little bit mysterious. So how many of you have actually looked at your NCDR data? Oh, I'm preaching to the choir here. Is your data reliable at an institutional level? Is there a mechanism for quality review? That got many fewer hands. How do you or does your institution input historical data which determine appropriate use? Now, this is a really interesting point, because if you do an H&P and then refer a patient for cath or intervention by one of your colleagues, and that H&P goes on the chart, the only data 3 months later that the inputting nurse might have to work with is that H&P. And that H&P may be just fine for your needs, but for NCDR data entry, it is a black hole. Nurses who are working on that, is this true? Yeah, black hole. Actually, I've put on your tables, there is, for each of you, there's a sample of the worksheet. So each of you can take that home. But in addition, at each table, there is a sample of the dictionary. And the dictionary defines all of the ways that answers should come across. I had to do a lot of exploring to find all the right answers, or the way to, not even the right answers, but the way to answer. And it turns out that if the NCDR folks do a quality review of 300, 500, 700 cases, they have the same bad data to look at. So they're going to tell you it's 90% accurate. Well, it's accurate to what your nurses inputting the data have, but it may not have anything to do with the patient. So somehow or other, we have to take responsibility. Our registries are really a wonderful way of what we are doing. And actually in Portland, when I moved to Portland in 1985, I met an incredible surgeon named U. Scott Page. And Scott Page was a geek. And Scott Page had, by that time already in 1985, 10 years of their surgical data. And once a month, they all reviewed their data, and they could tell when they were having too many infections or if there were outliers in their group. And they used that data for quality. And his database actually evolved into what we know partially now as the STS database. He was a leader and a visionary before his time. But there are other heart surgeons that we can think about. I want you to read what's behind Dr. Oz. That's Dr. Oz, for those of you who don't know. And it says, the most unnecessary heart procedure, the danger of stents. And he is, this is an interventional cardiologist in front of him there from Columbia. And he is telling people that not all blockages lead to heart attacks, and unless you're having a heart attack or about to have a heart attack or in pain, stents are usually not the right answer. Another study found that stent procedures or angioplasties are used incorrectly up to 50% of the time. This made the headlines. Dr. Oz says that half of all stents are unnecessary. Well, this comes from appropriate use criteria, and I just want to spend a minute talking about appropriate use criteria so that we're kind of all on the same page. The terminology is based on a RAND methodology, and it works in theoretical circles, in ivory towers, but it confounds the rest of us. The Board of Governors, and I, as your Board of Governor, the Board of Governor leadership has really been working hard to try to get the message to those people who are tied in very closely with the terminology that comes from RAND to understand how this terminology is impacting us negatively in the way we take care of patients. And we have asked them, and a message has gone to the leadership to consider a change in the terminology to something like appropriate, possibly appropriate for uncertain, and rarely appropriate for inappropriate. I'm just mentioning this. I don't want to get into a long discussion of this, but let it be known that this is a really important thing, and we understand that. So what is the NCDR? The NCDR started in 1998 with CAF and PCI, and it's grown over the years so that you can see that it's the most comprehensive outcome-based quality improvement program in U.S. hospitals. It's the premier source of clinical outcomes data. And it identifies and can identify and close gaps in quality of care, reduce waste and variations, and hopefully help us to implement effective continuous quality improvement processes. And that's part of why we're here tonight. There are actually over 2,500 hospitals that participate in the NCDR databases, more than 1,000 cardiologists, and 17 million clinical records. So think about this, incorrect 50% of the time. Well, Ty Gluckman and I, about a year ago, talked to Kathleen Hewitt, who is part of the ACC NCDR leadership, and we told her that we really wanted to try to bring this to our Medical Directors Institute meeting, and she actually worked wonders to actually pull all of Oregon's data for us so that we could look at our data compared to the national data, and our data compared to the Pacific states. And this is what we found. First of all, just to let you know that over 98% of all PCI stents done for acute coronary syndromes and MIs are appropriate. And when you add that to the overall appropriate use criteria of Oregon versus the United States, we had significantly lower inappropriate and uncertain and higher appropriate revascularizations. Now, we were pretty cocky that that was pretty good, and when we looked at the non-ACS patients, and that's really, this is where Dr. Oz's 50% comes from. It's something like his 39% plus 11% is where he comes to the 50%. The caveat here is that uncertain does not mean wrong. And when you read the RAND literature, uncertain is actually supposed to be characterized as okay. Uncertain means that there are not enough clinical trials with that particular clinical scenario to say whether it's right or wrong. Plain and simple, not enough data. It's not inappropriate, it's uncertain. And that is a concept that Dr. Oz doesn't understand and our patients don't understand. And worse than that, when someone's having an acute MI, they tell you stents are bad. This is looking at Oregon versus the Pacific US, and we still are significantly lower. And non-ACS were about the same as the rest of the Pacific US. But all in all, we were feeling pretty good about this, but as I said, Dr. Gluckman was frantically typing on his computer, and while we were showing it to representatives of payers from around the state, we got a preliminary look at some blinded data from the Providence Health Plan patients. And these are Dr. Gluckman's slides that I'm going to share with you now. These are PEB, the Public Employee Benefits patients that are in the Providence Health Plan for cardiac procedures, and this is divided by top 6 regions. And the important thing to see is that there's a tremendous variation in cardiac caths, stents, and bypasses that shows a regional variability. Tremendous variations in care. If you look at the presenting symptoms for these patients, the red is no symptoms and likely to be angina. Green is stable angina. Purple is unstable angina, and blue is non-STEMI or STEMI. You can see again here that there's a tremendous variation in care. This one, I think, is a little bit harder to interpret, and I will tell you that I think that hospital number F actually is a hospital that only does the PCI database, that there really isn't anyone who has non-obstructive disease in non-ACS patients if they're doing cath and PCI. There are 2 databases, and you don't have to participate in both. So I think that's what, but still there is everything from 32% to 45% of non-obstructive disease in non-ACS patients. That's a high rate of normal coronaries. Proportion of PCI in non-ACS patients eligible for appropriate use criteria, again, quite a bit of variability throughout the state. This is looking at the proportion of elective PCIs with positive stress or imaging study. And I would tell you that I don't believe the number should be 100% for imaging studies. I mean, certainly we all have patients who have known coronary disease and a change in their symptoms, and you know, there are many reasons why you might not go to an imaging test or a stress test in all your patients. But you can see that Hospital C only is documenting 15.4% of patients who go to PCI who've had some type of imaging or stress test. Now, that may be 2 things. That may be that they're not getting stress testing, that somebody with chest pain goes straight to the cath lab. That may be that we're not putting in our H&Ps the stress tests. And I would contend that it's probably both. This is the presentation of patients receiving PCI. You can see that for Hospital A, 63% of them, 64% present with unstable angina, whereas for group F, it's 27% that present with unstable angina. So so over 2/3 of their PCIs are in stable coronary patients. Canadian Cardiovascular Anginal Score. when was the last time you put a CCS anginal class in your H&P? Yeah. It's on the form, and the nurses are guessing. Appropriate use criteria in non-ACS patients. Well, Dr. Oz would be interested to see that our hospitals go from 81% appropriate to 43% appropriate. And uncertain is in the middle somewhere, but clearly up to 23% inappropriate. This is another tough one, 2 or more anti-anginal meds. And I think this is one I know Dr. Gluckman has trouble with, because he doesn't think that 25 milligrams of metoprolol is an anti-anginal med. But I think there's probably there's probably other things we could focus on. Statins at discharge. I don't know if this is just not being documented, but if people with coronary disease are not being discharged on statins, or it's not being marked as inappropriate. So anyway, data is often entered by data entry person quarterly, just in time. You know, they pull the charts at the end of the quarterly reporting period and frantically in 3 days go through all their interventions. The clinical data is gathered from the H&P prepared without awareness of the necessary data points. We need to input the history and risk factors, the results of stress or imaging studies performed, and their risk scores. Canadian Anginal Classification, the New York Heart Association Classification, PCI indication, and CAD presentation. I went through this just to show you that there are definite definitions for stress test positivity. And I actually have suggested in my office that we begin to start reporting on our stress echoes and nuclear stress tests, their Duke stress score. There are definite definitions here. The definitions are on the table. Risk or extent of ischemia, and it's very specific, but it's not very difficult. Stress echo scoring, and what is the outcome associated with the risk levels? Well, it turns out that the Duke treadmill score has been validated on tens of thousands of patients, and what they found is that the high-risk Duke score have greater than 3% annual mortality, the intermediate risk patients 1 to 3%, and the low risk less than 1% annual mortality. This is just more of the definitions, and I'm glad to give any of you who are interested in these the details of the definitions. But high. If you start to read it, TID means dilatation of the ventricle. And this is the actual equation for the Duke treadmill score, and the numbers that assign the low, intermediate, and high risk. So have you ever looked at your own NCDR data? I got a lot of yeses on that. Is your data reliable at an institutional level? I think we really need to take some leadership in doing regular conferences where we review our data and we see if we're doing a good job. How does our institution put historical data which determine appropriate use? And who is responsible for quality and reporting of our data? Are there changes you might make to your electronic health record in your office to incorporate adequate data for data collectors and your interventional colleagues? This is what I have to ask of you, and then I'm going to turn it over to Ralph Brindis. And that is, I want you to own, share, and use your data. Make the data transparent for quality improvement, and that's really the primary purpose of our registry. Be your hospital's champion. We are agents of change. I think this tonight, working with some of our payers and showing that we are all looking for quality in a way to improve the delivery of care, cut unnecessary cost, and take optimal care of our patients. Quality implementation is expensive, and we're going to have to convince our institutions that they're going to have to invest in doing it right. case review, data review, and collection review costs money. Thank you. Questions? Yes, Sanjeev.
As you know, most of the data are extracted by people who are trained to extract it from records. And that's where most of the problem lies, because definitions are not clear. They have to second guess people. And I think the best way to get rid of that subjectivity is to have data elements in a medical record related to each diagnosis that are going to be NCDR substantive databases, because that's the only way you're going to reduce error. Because if you leave it to people to sort of judge what happened in retrospect, you're going to get all sorts of problems.
So, Sanjeev, I want to comment on that. I think you're right about the fact that we need standardization so that the data is more reliable, because I think there is a piece of the registry. But one thing I do want to make clear is that there are some patterns in the care that we identified in the NCDR registry that correlate with our claims experience. So, for example, the high-use community correlates with a high degree of patients, a higher degree, it's not a high degree, a higher degree of patients getting an intervention for stable angina or asymptomatic or atypical pain, which I believe is related to surveillance stress testing, is the most likely part of the cascade. So, the spirit of this is to actually learn from it and create some transparency. And I just, wanted to thank the ACC, because they're showing a lot of national leadership. They're far ahead of most specialty societies. The work is really commendable, and it's really hard for a professional society to do this. Many of you know I'm on the board of the ACP, American Council of Physicians, and so I know how important that is that you speak to your membership. I wanted to thank the chapter. I wanted to thank the hospitals, because that NCDR data was a result of them being willing to share this with us in a non-blinded way to learn, and that speaks to their passion and interest for quality improvement, which may not be in their own self-interest. And I wanted to thank the physicians for coming and being willing to engage, because I think that's the profession that has to lead on this. It isn't going to come from the payers. It isn't going to come from government. It's going to come from us as doctors. And this is an excellent example of what we're trying to do. And I just wanted to explain my appreciation to the chapter. And I think it's the beginning and not the last word.
Questions, comments? We're going to have a Mary. Mary is one of the stars down in Medford.
I would just say that if you follow the logic, and I've been abstracting, looking at this data for 2 years now, that we're trying to pull cases together 3 months after the fact or whatever it is, right in time, when we're asking, was it appropriate? When we should be asking, is it appropriate? Like on the front end, and working that into Pinnacle or whatever database you work with in your practice. And then some of this becomes a moot point because it's addressed before the procedure as opposed to after.
Eric. George.
I think that's a great point, Eric Stecker. I think that's a great point. And one of the things I've noticed was not addressed here is the ICD registry. And I think most people who deal with the ICD registry think that there are serious shortcomings with it. And in order to be something that can be that data can be concurrently entered, it has to be, it can't have too many variables that are not clinically relevant. And that's where I think the ICD registry and the cath-PCI registry differ. The cath-PCI registry is detailed, but it has mostly clinically relevant variables. ICD registry has many things that are not clinically relevant. And so I think as we design these and think about these things, we have to really make it clinically relevant in a way that we can roll this in on a prospective basis and actually enter our patients' information in at the time, as you said.
Thanks. I'm going to let Ralph take over now. Dr. Ralph Brindis, I'm just thrilled that he agreed to come and join us tonight. Ralph is the past president of the American College of Cardiology, and actually in many ways is the father of these registries. He's shown leadership over the last so many years. Ralph and I actually started practicing cardiology together the same day, and hopefully we'll have a little more energy left in us to do it for a few more years.
Well, thanks, Sandy. I notice you haven't retired. I actually retired from clinical practice yesterday, and but I still have a lot to do in terms of quality, and I want to acknowledge, Bob, what your comments were, first for the leadership that you have and the whole hospital system is having here in trying to take this on. I consider you all visionaries and leaders, and is what I said beforehand, clearly Washington is actually looking at what's going on in Wisconsin and in Oregon to try to understand how we can be better about value-based purchasing, for example. You know, already you've come up with some of the answers in terms of appropriate use criteria. It is clear, and I want you to know that we're doing a lot of work both through the Society of Coronary Angiography and Intervention and also through the ACC in having a workflow tool that you would be able to proactively and prospectively enter your appropriateness criteria elements at the time of catheterization. It would be obvious that doing it at the timeout that we are mandated by the Joint Commission, that this would be the ideal time to actually go through justification. Prairie Cardiology, which Jim Dove founded in Southern California, actually has already incorporated this in their workflow. It's basically 5 questions. Sky has come up with a decision support tool that's web-based to do that. And clearly that's the right thing to do. To ask abstractors to try to do things retrospectively is absolutely crazy. So Sandy gave me a big topic to try to cover, and I really want to try to keep this kind of small because it's the dialogue that you've already started that's most important. But in addition to acknowledging that today is Sandy Lewis's anniversary, that she has given up her evening with her husband to help host this, we also, we should acknowledge that, and we can all send a thank you note to her husband. But we have to acknowledge what's going to happen at 7:15 tomorrow morning, because that's could change so much in terms of our delivery. Here we have the famous picture of Obama signing the health care reform, and the Supreme Court of the United States is going to reign and tell us whether it's going to, the Affordable Care Act is out the door, parts of it are out the door, or whether it's fully intact. So this is a big day for us all tomorrow, and I know Jim Fasoulis is already very busy trying to put together ACC statement related to that. Flipping a coin. So, you know, you may all have some ideas about what's actually going to happen tomorrow, and I want you to know that Las Vegas actually has come up with odds on what SCOTUS is going to do with the Affordable Care Act, and I wanted to share them with you so we can see if Las Vegas was correct. So, first of all, they think that there's a 50-50 chance that they'll outlaw the health care mandate. They think, and we know, you know, when this was made about a week or so ago, they predicted they would uphold the Arizona immigration law. There was a 3-to-1 chance that they were going to do that. They thought, Las Vegas thought that the upholding life without parole for convicted murderers under the age of 14, they predicted that was a 5-to-1 chance. They thought that the FDA regulations of holding that on fleeting obscenities, they thought there was a 2-to-1 chance that they were going to do that. But Las Vegas didn't stop there. They came up with some other nuances. They thought that maybe the court accidentally compels undocumented immigrants in Arizona to buy health insurance. The chances of that happening was 5-to-1. They thought that the court would allow undocumented immigrants to mutter fleeting obscenities. As they were being deported from Arizona, there was an 8-to-1 chance that that actually would occur. They thought that they could strike down the Affordable Care Act, the Arizona immigration law, and hold the FCC regulation on fleeting obscenities, and strike down its own opinion because Justice Scalia's concurrence contained fleeting obscenities. They thought there was about a 7-to-2 chance of that. And then actually that Scalia's opinion would actually contain fleeting obscenities was very high. It was a 1-to-4 chance on that. I don't want to take this too far, but they actually had a bet on whether it would hold health care mandate, but only if you're 14 and you have killed somebody. There was a 11-to-1 chance on that. They also may just take on Mitt Romney. They did it for Bush and many years ago as the winner of the 2012 presidential election, 15-to-1, before the votes are counted. But I like this one. The chances that the court would announce that they were all going to retire, form a reality TV show on which the justices play elaborate pranks in order to get Justice Thomas to ask a question. There was a 300-to-1 chance of that, but they went one further. That Thomas actually asked the question was going to be 90,000-to-1. So we'll see tomorrow what actually happens. So I'm sure you're interested in that. So I've shown this slide a lot. That is the accountability of the physician in the year 2012. Not only do we have to deal with quality and accountability, but we have to deal with cost. And so the AUC is part of that. And we're actually under, not only just attack, but look at all these mishmash of things that we have to deal with as clinicians and as hospital systems and EHRs and value-based purchasing, claims